Alrighty, this is the online version of a presentation I'm doing on the 8th of May 2024, slap bang in between International Day of the Midwife and International Nurses Day. As you can see, it's called Nurses, Midwives and the Empathy Trap, and making self-compassion our superpower. Alright, let's start thinking about who we are as nurses. Well, this AHPRA data, they put out a neat little infographic earlier on in the year and pointed out that 54 of AHPRA registered health professionals in Australia are nurses. Down the bottom left there, you can see those four. They are for midwives, but because for every 4 midwives, 3 of them are also nurses, I'm not really sure if they're counting them twice. So I think the correct number is to say that there's 55 nurses and midwives for every 100 health practitioners in Australia, but I might have that wrong. It seems unlikely to me that it's 58 nurses and midwives for every 100 health practitioners, but yeah, who knows? Ask AHPRA. It's important to know that we're a proudly female-dominated profession, said the bloke. But anyway, it's something that we can't get around. Midwives are even more gendered towards females and nurses, but it's really important to note and celebrate that the vast majority of nurses are females, nearly 90% for nurses and nearly 99% for midwives. And so most of my mentors and colleagues in nursing have been female, and I think I've been fortunate to work in that sort of industry where we're able to celebrate the power of females. It's interesting that when the Roy Morgan got around to thinking about nurses, so we'll just go through this graph just in case you can't work it out without just a little bit of a prompt there. So back in the 70s, they started thinking about, I wonder what people think of ethics and honesty of doctors and dentists. And then, so that was in the 70s, and they were rated pretty well. And then they thought, there's pharmacists as well. They thought about them in the late 80s. And then somewhere in the mid 90s, somebody went like, hey, maybe we should think about nurses too. Look, since we've been included in this little survey that they do, not every year, but fairly frequently, nurses have always topped the list of being the most ethical and honesty. Look, I don't think we should get too carried away about that for a couple of reasons. Look there right at the end, from 2017 to 2021, we lost 6%. All the health professions did, lost about 6%. That was during the pandemic, man. Like, who are these people? This is when nursing and midwifery were under the most pressure and probably at our finest. Not only were we ethical and honest, but we were hardworking and pretty brave, I reckon. Like, most of us kept on turning up, and it was a pretty frightening time. We were really fortunate in Queensland and in Cairns specifically, where we were saved a lot of that early stuff around the pandemic. Remember that there wasn't really a reliable test. It was before the vaccines became available. It was pretty hard to get your hands on PPE. And we were reading about how people overseas in the US and Europe and other places, that nurses were dropping dead all over the place. Hundreds, it turned into thousands of health professionals were killed whilst at work and picking up the virus. So we were really fortunate to be up here and have a government that had the guts to keep the borders closed until everybody who wanted to get a vaccine had a chance to get a vaccine. And so then they delayed opening of the borders until everybody had that opportunity, and the borders were thrown open in the middle of December 2021. So this is a area graph, and as you can see, the blue area is the total hospital patients here at Cairns Hospital, and with the ICU inpatients in green down below. So so if you can't just make out those dates, I'll just talk you through it. So nothing much happened for those first couple of weeks after the borders opened, and it wasn't really until the new year that we started to see this fairly alarming uptick in hospitalisations for people with COVID on the back of that Omicron wave. It went up really rapidly, so might be able to make up there by the 11th of January, the respiratory renal ward, which was the place for all the COVID patients to go at that time. That was chockers, so we had to expand the opera, the older persons unit. That was emptied out, and that too became a COVID ward. And then within a week or so, also had to open up Surge North as a COVID-only ward. And it was scary. These were really frightening times, those first 3 weeks of January, 3 or 4 weeks. And you can see there, right there at the peak there, that's around Australia Day, around the 26th of January. And at that stage, we had 3 wards pretty much full. There was a couple of spare beds on Surge North, but apart from that, it was chock-a-block with people with COVID. And it was a big deal. Like, I think in this period that we're looking at here, something like 80 people died in far north Queensland. So yeah, it was a big deal. And we were pretty scared. And it was difficult because we're doing everything differently. I'm not sure if you've ever had that experience where you switch from an iPhone to a Samsung or vice versa. Going from the Android operating system to the Apple operating system, just nothing falls to hand. Everything's kind of weird. You're slow and you're clumsy and you feel a bit stupid. And I think a lot of us had that experience. We were going about our business as best we could, but we were doing it all on PPE and it was all slow and clumsy and we felt a bit stupid at times. Nevertheless, having said that, a point of pride for the respiratory nursing team is, as far as I know, not one of the respiratory nursing team picked up COVID during this period. We were very fortunate that at that point where we were thinking, God, I've got 3 wards full of COVID patients, what happens next? Well, that Omicron wave crested and it decreased nearly as fast as it went up. But let's think about who was doing the hands-on work there, and it was the nursing workforce. This is a picture of a respiratory nurse or one of the COVID nurses on any one of those 3 wards who was surfing the Omicron wave as best they could. There were other nurses involved there, of course, too, the ED team, an ICU team, and others around the hospital were compensating for those wards being offline for regular patients. So everybody was playing a bit of a part. And this is where it's really important to think about the psychopathology of us, of nurses, is that not only do we turn up and try to be brave, but also I think in many cases we were putting the needs of others before ourselves. This is something that's pretty habitual for a lot of nurses, I think. I think part of the reason we get rated so high for ethics and honesty is that people actually see that empathy and they think, oh, good people are empathetic people. And yeah, that's probably true. But a hallmark of our profession is around that empathy. But that kind of paints us into a corner a bit, because when you're being an empathetic health practitioner, often you're putting the needs of your patients and their family and the organisation that you're working for before your own needs. And that's not very good for nurses and midwives. This next graph is a confronting reminder of that. So let me just walk you through it quickly. Boys are blue, girls are green in this instance. And you can see here that this is about suicide rates per 100,000 per year. And it's pretty confronting when you're a nurse. So we're comparing ourselves to other professions here. On the right-hand side of this graph are other occupations, and on the left-hand side are nurses and midwives, with the other health professionals, the allied health, and the doctors in between. So it's important to have a look there. So male doctors suicide at about the same rate of males in other professions. Male allied health are at a bit of a lower rate. So that's kind of interesting in itself. The not so good news is that for female doctors, they suicide at about twice the rate of people in other professions. So female nurses, they also suicide at a bit over twice the rate of females in other professions. And males are up there. As a percentage of male suicide in other professions, it's not quite so alarming, but the overall number is very high. male nurses suicide at about the same rate as defence personnel who leave on their own terms. Defence personnel who are medically discharged, they suicide at about 3 times the rate of what male nurses do, and other defence personnel who leave on their own terms. But anyway, it's very high, and it's a bit scary. And I think, like when we talk about suicide, not only is it confronting, but it's also really complex. But it's important to remind each other that suicide isn't always because of a psychiatric disorder or an untreated psychiatric disorder. Very often it's something that somebody intoxicated will do or try. Very often it's around despair or anger, not necessarily psychiatric disorders. And very often I think it's because people just can't think of another way out. And that's a bit of a worry. I wonder whether it's our empathy that makes us find it difficult to find a way out. We feel that we have to be the caring guys and keep on turning up to work and doing the right thing. And I wonder whether that's one of the many contributing things, along with shift work and secondary trauma and all that sort of stuff that makes nurses more vulnerable. Right, I'm going to move away from that and start thinking about what can we do to escape this empathy trap. Well, we should start with thinking about self-compassion. Now, just by way of explanation, I used to talk to grad nurses and whoever else would listen about self-care, but I stopped doing that a few years ago because it just felt like self-care was giving busy people another job to do, whereas self-compassion is more about an attitude and turning that empathy that we have for others, turning it back on towards ourselves. So self-compassion, as we've got defined here, is being empathetic and understanding towards oneself as you might to a close friend in times of suffering. And I'm not sure that we collectively are always very good at doing that. So how do we turn that attitude into action? I've got a couple of ideas which I just want to run through in the time that we've got together. So this one, gather round kids, Uncle Paul's got to tell a story. Back in the early 1900s in Wales, some of the Welsh miners were saying, well, isn't it great that we've got a job, but at the end of a long shift, I have to trudge down from the mine to my miserable little miner's cottage, and I have to use all my hot water to have a bath to get off all this coal dust and the grease from the machinery and all that stuff. And then I've got to wash my clothes and And effectively I'm adding on another hour for every day, and I'm using my resources at home for the boss's benefit. And so really, if I'm getting dirty on the boss's time, shouldn't I get cleaned up on the boss's time? And the other miners listened to Dave the miner say this. It could have been Dave, I've got no idea. And they said, yeah, that's a great idea, Dave. Why don't we go tell the boss about it? And they went and told the boss about it, and the boss went like, oh, that's not a really good idea. I couldn't possibly do that. We'd go broke. So they went on strike, and they stayed on strike for months and months and months. Some of these mines were shut down for more than a year. And at the end of it all, they got some improvement in their wages and conditions, but including having what's called pit head baths, where you get cleaned up at the end of your shift, you drop your dirty overalls into a laundry basket, somebody else washes them for you, and you go home clean, and you get paid for that time to get cleaned up. You're doing that on the boss's time. And you'll remember there from when Todd and Brant spent 2 weeks underground in Beaconsfield, and it was announced that they were going to be recovered safely and that they'd been released from the confined area that they're in. But they took a fair while to get to the surface, and that's because built within the infrastructure of the mine was a spot where they could shower and shave and shampoo and change clothes and do all of that, and then they clocked off. And so that's a really powerful analogy. Now, why am I talking about this? We nurses don't get covered in coal dust all that often, but we do get grubby. Not only do we do knowledge-based work and skills-based work, but we also do emotional labour. And of course that's going to affect us, of course it will. To pretend otherwise is ridiculous. Now, rather than be reactive to the emotional turmoils and stresses that we get exposed to. There's been a thought around for quite a few years that we should be proactive around that. So if you're thinking about critical incident stress debriefing, that's like asking a firefighter to put out a fire. Clinical supervision is a framework which is more like about doing backburning, preventing the fire from getting out of control in the first place. Clinical supervision has been around in mental health for a long time. In the early 2000s, the policy for Queensland around clinical supervision in mental health intentionally left out nurses, which was really ridiculous and made viewers pretty cranky. The rationale at the time by non-nurses was that there was too many of us and it'd be too expensive to take us all offline to get the same opportunity to do some backburning, emotional backburning that everybody else is doing. But we were reinstated formally in time for the 2009 update to the guidelines. And so any nurse working in mental health has had the right to take some time out of the workplace to sit down with a trusted other and reflect on practice. That's what clinical supervision is. It sounds like scrutiny, but it's not. It's a thing for us. In 2019, the Australian College of Midwives, together with the Australian College of Nurses and the Australian College of Mental Health Nurses, put out this joint position statement saying that clinical supervision should be available for all nurses and midwives, not just the mental health nurses. And then a couple of years after that, the Office of the Chief Nurse for Queensland put that suggestion into action by way of a clinical supervision framework. And this document sits as a PDF on Quips if you want to go looking for it. But it says basically it's an amalgamation of both the position statement and the existing clinical supervision guidelines for mental health services. And it says that, all nurses and all midwives, no matter their role or length of training, should have the right to have some clinical supervision, some protected time away from the coalface to reflect on practice. So for those who aren't familiar with the functions of clinical supervision, I like the way that they're articulated by Bridget Proctor back in 1986, and she spoke about these three primary factors. The formative is where you create new skills or get new knowledge. The normative is making sure that we're staying within the guidelines that govern our practice, whether that's hospital code of practice or policies, procedures, that sort of stuff. And then the other function of clinical supervision, the bit that I value the most, the bit that the mental health nurse values the most, is the restorative aspect of clinical supervision, where you get to reflect on your practice and how it's been affecting you. I think as a knee jerk, when people think about getting all the nurses offline, they think, we can't afford to do that. Getting nurses and midwives just sitting around talking and thinking and reflecting on their practice. But from a safety perspective, we can't afford not to. And two reasons: we saw that suicide data. We need to create a safe workplace for ourselves and for our colleagues. But also, if you get burnout, or let's call it empathy failure, that's really bad for patient health outcomes too. If you've got a burnt out nurse at the end of the bed who really doesn't give a rat's whether that patient has good care or not, that's really creating a risk for the patient. So we're doing it not just for ourselves, but we're doing it for our patients as well. Two last things to finish on around this self-compassion. It's good to have a bit of an understanding of what an acute stress reaction is. There's no normal reaction to an abnormal situation, and most of us at work get exposed to really abnormal situations. Jump onto Quips when you get a chance, search for those words bloody stressful, and this little PDF should come up. It's been sitting on Quips since the late 90s, and we update it every year or two just as things change. And it's got quick and easy access to some tips and tricks that you can use and your family can use. Steers you towards support agencies, including things like the Employee Assistance Program and what have you. And then the last thing, which I'm really excited to tell you about, and I invite you to grab your mobile phone now, because I want you at the end of the session to walk away with these two organisations in your contacts list on your phone. So the one on the right there, Nurse and Midwife Support, that's been up and running for must be about 6 years now, I think. 24 hours, 7 day a week phone support for nurses, midwives and our students, including AINs too, in Australia. And you'll get phone support from them. Think of that as a bespoke lifeline for nurses and midwives, and they'll help you problem solve your way through. And then just launched in April 2024 is this new one, the Nurse and Midwife Health Program Australia. And it's interesting, I'm just going to jump back to the other one, the Nurse and Midwife Support. When that came out a few years ago, 5 or 6 years ago, Beth Moll, who was the secretary of the QNMU at the time, she was up at visiting the hospital when I got introduced to her, and I was saying, oh, isn't this good that we've got that up? And she was like, yeah, is it? And I was like, oh yeah, no, it's really good that we've got something. And she said, yeah, probably better than nothing, but I think we can do better. So the Nurse and Midwife Support thing, we pay for that ourselves. Some of our APRA money gets quarantined to run that organisation. The unions, including the QNMU and then all the branches, the ANMF, they thought, yeah, we can do a fair bit better than that. And they advocated to get federal government funding for this bespoke organisation, Nurse and Midwife Health Program. And so that's funded by the federal government and it's union endorsed. The unions really fought for it. It's Monday to Friday, business hours. At rollout, they're going to have 4 hubs around Australia. There will be 1 hub for both Queensland and the Northern Territory. I'm assuming the people on the ground for that will be down in Brisbane. But I'm also assuming or / hoping that as the program gets settled in, that there might be access to face-to-face counselling here in some of the regional cities. But look, do grab those QR codes so you've got those contact cards on your phone. If you never need them, that's great. But if you or one of your colleagues ever get to that point where you think, I'm falling into an empathy trap here, I'm falling into empathy failure, I'm burning out, or I just really need to bounce a few ideas off somebody on how to keep my head above water, isn't it good that we've got bespoke organisations to look after us? It'll be nurses for each of them. It's nurses and midwives helping nurses and midwives. Who else understands our peculiar profession? So that's everything I'm planning to talk about. Thanks for tuning in. Please share those contact details around those organisations to help us. Cheers.